So we're coming to you, hosting this session on the unceded and ancestral territory of the Coast Salish peoples. That includes the territories of the Musqueam, the Squamish, and the Tsleil-Waututh nations, as well as the Métis chartered community of the Lower Mainland region. And wherever you are in the province or anywhere on Turtle Island, we pay homage to elders past, present, and emerging, and also attempt each day to learn more and understand more about the Indigenous populations and the lands that they've kept for us, and promise to work with them to keep them close to us as well. Next slide. Province-wide rounds, as you know, is a collaboration between the University of British Columbia and BC Renal. Our industry partners contribute to the education of all, as do all of you in the health authorities across the province. And we're really grateful to be able to bring to you such a diversity of topics, speakers, and stimulate both education and curiosity. So thank you all for that. So it is with great pleasure that I actually can introduce Dr. Lap Cheng. Dr. Cheng is completing his home dialysis fellowship here in British Columbia, coming from University of New South Wales in Sydney, Australia, where he has completed his nephrology training there and also has a Master's of Science. His particular interests are in electrolytes as well as home therapies. And without further ado, I'd like to pass it over to Dr. Cheng to give us an update on Home is Best. Yeah, we can see your slides perfectly.
Hold on. Yeah. Good morning, everyone. Um, yes, I'll unfortunately be going back to Australia soon, although I can't say that I will miss the fact that it's 7:30 and it's still dark outside, so that would never happen back home. But today I'm going to talk about how home is best and the best practice guidelines for home hemodialysis, exploring the pathway from hospital to home. And I've been working on this for most of the year under the supervision of Dr. Chris Poynin. So launching right into it, um, this is just an outline of what we're going to talk about today, a bit of background about the guideline and how we went through the creation process, as well as some principles for home hemodialysis. And then I'll be talking about a few key topics from the guideline, obviously not everything in the guideline, but some of these things include an algorithm that we came up with, challenges to eligibility and training, access considerations, some training content, and then what we'll be doing moving forward, and hopefully a bit of time for any questions. So the background to the guidelines. Well, of course, the guidelines are surrounding home HD, which we all know is an important treatment option for patients. And there are several programs across BC. They have varying sizes, staffing, processes, and practices. And we conceive the best practice guidelines, much as other guidelines that have already been established for KCC, as well as the PD guidelines, to act as a tool to help support introduction of new staff, as well as potentially any new programs, whether they be in the province or elsewhere, to standardize the practice across programs and link them where possible to evidence-based medicine. There are also topics specifically for planetary nephrology, and importantly, collation of guides, links to more in-depth BC renal resources that are already established, as well as QI metrics and key performance indicators to ensure continual improvement in our programs. And the guidelines, as I said, took most of the year, and we started that with a literature review. So looking at first at international program guidelines, so that was to compare to what we were doing, as well as identifying any areas of conflict or potentially for adaptation. And then there are existing BC renal resources which were reviewed and readied for inclusion. And then went on from this to do a more detailed database search for any other guidelines, particularly in key topics and areas that were found from the initial review of program guidelines. And some of these themes were that most of the evidence was really around patient recruitment, eligibility, and barriers to their progression and training through Home HD. And, unfortunately, there's pretty scant coverage for Home HD specific literature on any of the other topics that are important, things like training, ideal program requirements, how to best monitor our patients. And across the board, the study evidence is often limited. This is usually based on a single center observational data or expert opinion, or extrapolated from other areas within nephrology, such as the in-center hemodialysis population and peritoneal dialysis. But we did move forward from this to send out surveys, which were a series of questions to our Home HD educators. They were surrounding the themes that we just identified, as well as other areas of interest that we decided upon after consultation with expertise within the working group. And this was not only to identify aspects of the program that might need standardization, but also to try and add refinement or development where necessary. This led to some focus groups that we did. One of them at the face-to-face Home HD educators meeting. And again, it was to collate further provincial practice patterns and get, direct insight from them into the challenges that they experience, day to day, as well as some early opinions and feedback about some tools and algorithms which we were generating for the guidelines, which we'll have a look at today. And the data, the opinions of the educators and what we collated from the literature surrounding some of these ideas about suitability and functional assessment, barriers to training, machine selection, vascular access, program infrastructure, and importantly, aspects of the training programs within Home HD, which of course key to get our patients to be independent. And we went from this to some content creation, again, some of which we'll be going into a little bit more detail through the rest of the talk. But these are some of the topics that ultimately have been included into the guideline. And before we do talk a little bit more about those features, I just want to refresh everyone with a brief overview of Home HD. In fact, these aspects themselves are contained within greater depth in the guideline. And what am I talking about specifically about Home HD? Well, I guess the key part of it is that there's different prescriptions that are individualized, mainly with flexibility and frequency being the key point of difference between Home HD and facility-based or in-center HD. Now, I outline these not because they're the rigid schedules that have to be adhered to, but these ones here reflect, you might consider, the classic prescriptions considered in the evidence base. And the first of these is the conventional hemodialysis type modality, where although the patients do perform it at home, they actually do similar hours to what an in-center patient might have. And so that would be, 3 sessions per week, 3 to 5 hours, totaling about 12 hours per week. And then for short daily hemodialysis, they're doing much more frequent sessions, 5 to 6, perhaps with a slightly shorter duration. But even with this, they'll be approaching 15 to 20 hours, so significantly more than an in-center patient. But truly the extended hours are when we get to nocturnal hemodialysis, first with alternate nightly, reaching up to 8 hours, doing on average 3.5 times per week. And so that's already approaching 30 hours. But nocturnal hemodialysis, where it's done almost every day of the week, with this, patients can be approaching 40 hours. Now, typically, a British, within the province, patients are typically on something not quite as extended as nocturnal hemodialysis, probably somewhere between conventional and short daily, doing perhaps 4 to 5 sessions for 3 to 4 hours. per week. And they'll be doing that with one of two machines. So the first of that is the AK series, which is very similar to an in-center machine, operates in the same way with a high efficiency sealing using high dialysis flow. Now, this is a key thing because with this high flow comes much higher water and waste needs, so up to 400 liters per treatment. And this impacts multiple areas because having that much water would overwhelm, for example, a septic system, or if the patient was relying on a well for their water supply, or other, sort of non-town connections. This also means that they need much more complicated plumbing requirements, which means that they almost always need renovations. And this can impact patients who don't own their own homes or live in small condos. The machine also uses reverse osmosis, which is, again, the same as in-center machines. This does help in areas that are at risk of boil water warnings because it's stronger in terms of its antibacterial process, and it does also allow short notice for treatments. The patients can hook themselves up and start a treatment at any time of the day without necessarily having to have planned ahead beforehand. I guess we compare this to the other machine, which is Next Stage, which does a different approach to dialysis with a lower efficiency, low dialysis flow model. And this does introduce a total clearance saline of what can feasibly be done in a week. But for most of our patients, even though it is a lower efficiency, the lower clearance does not actually affect them clinically. So they can be considered very similar. There is much lower water and waste needs, a maximum of 80 liters per treatment, and usually less, which means significantly less draw on any water or septic systems, and it needs less renovations and is easier for patients who might be living in small or remote areas. Another key difference is that it uses a deionization purification principle, which takes time essentially, and patients may have to leave their machine overnight, creating a batch of dialysis which they can use. So they can't actually do treatments at short notice. The machine is relatively simple. It has an analog interface. It does have some limitations to what can be done with it. For example, potassium bars can only be set at either 1 or 2, compared to a range of different possibilities for an AK machine. But its simplicity may actually make it a little bit easier for patients to understand in terms of training, which is obviously. And I just use this opportunity to point out some those differences with water usage and an environmental basis. So this was a life cycle analysis, which is collating everything that the contribution to the environment that the machines from manufacture to the end of the patient's time on therapy, including transport of the supplies and building of the machine, as well as operational costs. And we see here these bars are orange refers to conventional in-center HD, the yellow bars are the AK series, and these green bars are Next Stage. And this is the conventional 12-hour per week prescription, whereas these are referring to extended hours nocturnal. But I just want to draw your attention to the water usage, it being well over 20,000 liters versus under 10,000 for Next Stage. And these various measures of environmental impacts, all different, validated in different ways to show impacts on the environment, but basically show that, of course, the trend is that in-center HD uses much higher environmental impact with a slight edge to Next Stage in terms of home therapies. And why is there such a big difference apart from the water usage? Well, it's because the patients are at home. If they're at home, they don't need to commute, which is a significant part of the impact for in-center dialysis. And this was based on a 30-minute commute. And of course, many people have to travel further than that. So in fact, the impact could be higher, as well as infrastructure costs. There's certainly a big difference Yes, it's offset a little bit by the fact that there's more consumables used by patients on home hemo because they do have to use dialysis. They do conduct their dialysis more frequently, and they do need the supplies delivered to them. But certainly, I think this is something that we need to keep in mind alongside any of the other clinical and quality of life benefits for our patients. Now, across British Columbia, we do have a fairly even spread of patients, a total of 143 as of September. But one of the reasons that we're doing this talk is we'd obviously like to see those numbers increase. And why is that? Well, of course, there are a number of benefits that are associated with home HD. Unfortunately, the evidence is there is some limited RCT evidence, but it's mainly observational, and there's no head-to-head data between home HD modalities per se. But importantly, there's reduced all-cause mortality, improvements from a cardiovascular standpoint, particularly regression of left ventricular hypertrophy, and improved phosphate and blood pressure control, which lead to a lower medication burden. And there are better quality of life metrics across a range of different scores. And I think mainly for, this is exclusively for the extended hours nocturnal HD, but for our female patients, there are definitely superior pregnancy outcomes. But this does have to be balanced against some disadvantages. Of course, they're doing more frequent dialysis, so there are frequent vascular access, which means increased interventions, participants, and risk of hospitalization for infection or access-related reasons. And as mentioned, there are some increased supplies which can have a burden on the patients themselves. And importantly, and we'll be talking about this a little bit more later, the self-cannulation is complicated by needle phobias. For extended hours, they have anticoagulation exposure and do need to be watched for any blood leak. And paradoxically, some patients can actually have higher interdialytic weight gains because they, I guess, use the fact that they can dialyze for longer as a reason to not adhere so closely to their fluid restrictions. And for the short daily HD sessions, they can actually, because they do have some leeway to adjust the prescriptions themselves, they could potentially input unsafe UF rates for each hour. And with that in mind, we have to think about, what kind of patients are going to potentially benefit from these modalities. The so-called conventional hours, they would be for patients who still have significant residual renal function and mainly will be able to, the points that they can do it during the day. And then if they need any nurse assistance, they can and that the short daily, the priority is really flexibility in people who can't perform nocturnal dialysis. But for people who really have daytime commitments and are able to do nocturnal hemo, this is best for them because, of course, they have that whole day free. In particular, the more frequent modalities get rid of the dreaded sort of long 2-day break. And as I mentioned, the pregnancy outcomes for nocturnal hemodialysis are very important for that subset of our population. All right, and then from there, I wanted to launch into what selected parts of the guideline. And we'll start with the patient flow algorithm, which we created to be an example of the patient's journey from recruitment to independence on home HD. And it reflects the consensus of not only the current practice within British Columbia, but also mirrors recommendations for successful programs that have been identified in the literature. And so those are things of like providing free education, having a standardized referral process, incorporating multidisciplinary approach, having a vascular access support, and having a structured training program with capacity for follow-up for patients and provide to monitor them and potentially respite. Now, these steps are set in this order, but they're not totally set, and they can occur in a slightly different order depending on how each patient presents and for the practicalities to, within each program. This is just an example. of what might happen. Looking into it a little bit more closely, this is specifically the referral section, which I think everyone will probably be familiar with the referral project that's been rolled out across the province. But again, the literature really emphasizes the standardization of recruitment, early education, especially if it's specific to home HD, and educating all of your staff so that this will increase the chance of a patient's exposure to a home HD education and an early referral. But after the referral process, then it moves on to the assessment progress, which is midway down here. And this is, when the patient actually comes to the home HD program or unit to be seen by the team, they about the machines, somewhat like I've just given to you in the earlier section. And importantly, one of the common international tools that is used to aid in this process is the MatchD tool. And so this is just an example of that, what it looks like. It was developed to aid nephrologists and dialysis staff identify and assist candidates for home HD. Of course, anyone who's here in the green box, you want to recommend it to them. And of course, red would be things that would just make it too difficult. But the yellow box here, this is the opportunity, patients who have some difficulties, but we can still intervene. And these challenges could be identified as I mentioned in the assessment section, but also during the training process itself. And that's what I want to give a little bit more detail on now. I think that it's important to focus on this because we do want to maximize the patients that we have on home HD. And if we discuss these barriers or challenges that could be encountered, we prefer that patients come even if there are some doubts, so that we can properly assess them. And you might be surprised at some of the things that we can address. The first of those is what we would call situational challenges. So there are three main categories: situational, psychological, and functional, that can cause problems with progression. And situational barriers can be particularly difficult to overcome. For example, issues with inadequate housing contributed to at least 20% of training or technique failure in one study, particularly in those who rent their homes. Now, internationally, in other regions of Canada, government-based funding is available to support home modification financial barriers, as well as assisted home HD through carers or nursing assistants. Now, unfortunately, at the moment, Ontario is the only place that provides home HD nursing assistance in Canada. However, in better news, the subsidy angle is being actively considered within BC. So certainly watch this space in terms of extra support there. But if the patient doesn't have an adequate water supply, and there can be other flexibilities in terms of using a dialysis care partner, which will be something that I'll refer to over and over again through some of these challenges, because it is one of the most the strongest aids that can be given. And this is particularly important for functional challenges. So I've grouped these into what we might call difficulties with self-management. And again, as I said, care partners here would obviously be very important to help people with their hygiene or frailty, issues with cognitive impairment, something that we see commonly even with peritoneal dialysis, the other important home therapy. But in this situation, I want to emphasize that it is important to involve other health providers, geriatrics, family medicine, physio and OT, community nursing, and home care to support problems like personal hygiene and free up more time and energy for the patient to focus on. So, um, and finally, medications or other pharmacological agents can be used carefully in order to help patients be more stable. There are other functional concerns, which I guess, might be the more traditional ones that we might think of: hearing impairment, visual impairment, or learning disability. And they can be a little bit more straightforward to address in a sense, because there's a focus on training aids, prolonging training, um, thinking about how you're setting up the training so that they can succeed. So if they have hearing impairment, they might use light vibration-based alarms. If they have a learning issue, then perhaps you need to look more carefully at the best way that their learning style, and we can always prolong the training as needed, just to make sure that they meet their goals. Um, Finally, the psychological challenges, I've just grouped them all together because, fear and anxiety surrounding the dialysis process and, of course, its potential complications among the top three patient-perceived barriers. And, that it's very complicated and multi-pronged, requires a supportive approach, particularly from um, the staff in order to hopefully, push patients to at least try and start dialysis, because starting training can, in and of itself, start building confidence. And in particular here, this is why the early education is important to try and dispel concerns that the patient have, about complications, or the feeling that because they're outside of the hospital setting that they're somehow getting, suboptimal. But one of the fears here, self-cannulation, is one of the things that I really want to focus on next as part of considerations for access. So as you could probably imagine, self-cannulation being so key to the home dialysis process can be particularly difficult to overcome. It's even worse for patients who have already been on in-center hemodialysis because they've already been exposed to cannulation and may have had a past traumatic or unsuccessful experience. And, the patients are afraid of multiple things, the pain involved, what if they cause bleeding? What if they aren't successful? What if they feel like they don't have the ability to do it? And with this in mind, there are multiple ways that we try and help patients, get through this issue. So it's been conceptualized into three steps that they try and gain control. So you're trying to let them take control of their own needling, perhaps via desensitization techniques, such as using a smaller needle that you might otherwise use for insulin or erythropoietin injections, and to try and remind them why they're doing this. So they're doing this to achieve greater control over their lives and take control of their treatment. And this often can help outweigh fears and hesitations regarding the cannulation itself. Once you have them in this thought process, it's also important to build confidence and particularly a sense of safety. So how we do this? Well, apart from just practicing with them and gaining experience, using the support of family and other staff, as well as how safe the patient feels. So this is important. Having skilled cannulators as the trainers is important so that the patients feel like what they're doing is safe and they're learning from the best people available. And then you make the cannulation routine. So once they review self-cannulation as an integral part of their treatment, it becomes normalized, and they treat it just like any everyday activity. There are other ways that could be helped along. Of course, they could have the fistula marked out on their skin to help visualize the anatomy and the direction that they need to do their cannulation. Of course, there's topical analgesia, exposure therapy, and relaxation techniques. There are some adjunct cannulation techniques that I want to touch on briefly. So tap cannulation is where the needle still has the cap on it, and you just tap it on their arm. I guess it's sort of like an exposure technique just to get them used to the idea, and then you progress to using a blunt needle and press it over the area, and then finally progress to a sharp needle. Um, and then there's tandem hand cannulation. So in here, the green glove, that's the nurse, and then the patient puts the hand gently over the nurse's hand to sort of feel the process of putting the needle in, and from their perspective, they can maybe only see their hands going and pushing the cannula in, just to normalize the process psychologically for the patient. But even equally as important to being able to cannulate themselves is to decide on the cannulation type. So this is unlike in-center HD because, again, the ease of self-cannulation is very important. And for some patients, buttonhole cannulation is less painful and easier to perform. I mean, you have to be doing this for them. A lot of them are doing it one-handed. So which one should you consider for your patients? Well, high quality data is lacking about which type is superior, and most of the evidence is related to in-center hemodialysis, where the suggestion is that there's an increased risk of infection and bacteria with buttonhole. But on the flip side, buttonhole could be associated with fewer thrombotic complications and increased fistula survival, which is also important given how often we're accessing these patients' fistulas. And KDOQI guidelines do recommend that access be avoided with buttonhole unless there are a few considerations regarding short segments or aneurysms, or I think importantly, if your cannulators have known that they've got excellent hygiene, they've got good cannulation technique, they're very comfortable with the technique, then it's certainly a viable option. And with that in mind, we have this quick reference guide that's in the guideline talking about some of the comparisons between the two modalities and what you might be thinking of. So as I already alluded to, if there's a short usable segment so that you don't have space to do rope bladder cannulation, you could set up a buttonhole. But on the other hand, if there are issues potentially with infection or immune suppression, so for example, any past infected endocarditis or the presence of a biomechanical valve, those are contraindications to using buttonhole. We'll have to teach them to use rope bladder. But a lot of the patients do find that if they have problems with needle phobia, that buttonhole can be the technique for them. But the consideration for buttonhole is that it does take a little bit more time in order to train patients, and you do have to consider that in terms of performance. And as a key part of training, I thought I'd use that opportunity to move on to some of the aspects that are within the training program itself. And this is part, again, referring back to the flow algorithm. We see that we've sort of touched upon some of these topics already in terms of machine selection and some of the aspects of home assessment that used when we're selecting the machines. But for the training itself, the length varies from 4 to 12 weeks. It's quite a wide range internationally. That's because there are different populations, different practices. For example, in the US, they often pick patients, the best patients, the most capable patients at shorter training times, whereas perhaps here in Canada, we stretch that a little bit, pick patients who are maybe a bit frailer, a bit older, have other difficulties, and take longer to train, and that's fine. But typically, we'd say for scheduling purposes, 6 weeks with 4 sessions per week is the starting point that we would use. And regardless, as I mentioned earlier, the training can be continued beyond the 6 weeks as long as the patient is meeting their goals, they're being able to perform all the procedures to safely recognizing contamination and infection? How will they respond to an emergency situation or troubleshooting? But if that goes outside of what they can do, they need to understand when and how to communicate with the clinic or get themselves to the hospital. I think importantly, the consideration in the literature is for whether or not to do some kind of assessment or an OSCE. Now, there is evidence out of Ontario which indicates that performing some kind of testing before the patient leaves does improve the patient's confidence and they feel that they are ready to go home, although the longer term impact on whether or not this actually helps techniques is unknown. We are currently doing a pilot program at Vancouver General to see the utility of an OSCE, and hopefully that will go well and be considered for rollout. And this is an example of what example schedule would be for the patients. So for example, here in the pre-training or assessment period, the nurses would focus on the kind of learning style, adult learning style the patient needs. Are they a visual person? Are they a hands-on person? Do they work better with videos? Is it or do they like reading books? And the guides just in front of them instead. That can be individualized in training. Week one, they would focus on just the basic things: set up, how to take care of their fistula or their central line if they still have one, as well as the basics of prescription. And then it gets more complicated, how to take care of the machine. What happens if something goes wrong? What if there's an emergency? And we've proposed having these checkpoints at the 2 to 3 week mark. That's as a point to touch base with the MDT, have the nephrologist involved, of course, in order to make sure that the patient is progressing through their training. And this is the first point in that pilot program I mentioned, where the patients are undergoing an OSCE, not punitively. It's to make sure that they're progressing well through their training and identify any areas that need further work. So that's what they would be doing here, reviewing areas identified in their assessment. And then they would, at the end of their training, they again would go through another assessment. And this second assessment is one that they must pass, in a sense, in order to be able to go home, because they do need to meet all of the final requirements for their CFP. So far, the OSCE is receiving good feedback so far. So again, watch this space for it. Now, finally, I did also want to point out that, of course, I can't go through the whole guidelines. So we have talked about some of the things here on the left, mainly about programs and program requirements, the machine selection and vascular access, as well as training. But the guideline also contains recommendations regarding aspects such as recommended clinic appointments, frequency, what laboratory tests are generally done, when to do home assessments, and what kind of emergencies and the responses that should be done for these for the patients. The key performance indicators, as I mentioned, are important in order to continually improve any program that has been set up. And then there are further topics on special topics such as planetary nephrology, as well as special populations, such as rural, indigenous, and pediatric populations. We also have a section specifically for advanced care planning and other logistical aspects from the program, such as staffing, the roles and responsibilities, training resources, vendor interactions, and so forth. So, again, I want to emphasize that the purpose of the program is to help generate interest and promote the use of home hemodialysis, as well as providing some of the solutions that could be done, and emphasizing that referring if you're unsure whether the patient could go forward with home HD is definitely preferred, um, and that that it would act as a tool, for anyone within BC to access and get an overview of what's involved within our programs. Now, moving forward from here, we are just in the final stages of drafting for the document itself. And it's after we do that, it'll be put forward for final committee reviews, as well as a bit of polishing with the design team. And then hopefully after that, it'll be published on the BC Renal website, and would also be available on the Share Source platform for Home HD. And hopefully as well, perhaps a few selected sections will be able to be published in journals to increase the exposure of the guidelines internationally. And with that, I'll open up the floor to any questions. Thanks for your attention.
Great. Thank you for that, for all the work that went into that, but also for that great presentation and overview for all of us, and some of the reminder of the nuances of both training as well as the different machines and issues facing. So open for questions on this dark Friday morning, which is slowly getting lighter out. Comments or questions from the 80 participants that you had online listening eagerly to everything. Oh, now down to 79, but can I get people to?
I think I've raised my hand.
Mike.
Perfect. Lap, I just wanted to congratulate you, Chris, and I think Salma particularly as well at the Renal Agency for this work. For the crowd to hear, the challenge that got set down for Lap was to get this done in time for him to complete his home fellowship in the course of the year. And I think it's quite remarkable the amount of work you guys have done. This I just really want to emphasize how much time and effort, both in terms of collating the information that's out there, recognizing how much is opinion based, and trying to enhance that with focus groups you guys have done is really impressive. And to my knowledge, this is going to be the most comprehensive practice guideline for home therapy. So I definitely think it's well worth getting that into the public domain. I just wanted to comment as well that it's been kind of interesting to see how many of the sort of the side projects, like the referral project, like the curriculum for patients who are quote unquote crashing onto dialysis, how this all really maps nicely into the work that you guys have done. So I just really wanted to acknowledge the work, Lap, that you in particular have taken with this, and I do think it's a valuable resource. When we started the home program way back, we had a fairly homogeneous approach to it across the province, but as programs locally evolve, then there's lots of changes that happen, and I think this is a helpful document to bring programs back together in terms of trying to have a unified and similar approach to things, but also valuable. We have occasionally had new programs come online, St. Paul's recently and Penticton reinvigorating, and this sort of a document I think will be really valuable for programs starting up or restarting to make sure all the ducks are in a row. So I just wanted to acknowledge the work you've done and thank you for that on behalf of the province as well.
Yeah, thanks, Dr. Copeland. Yeah, and I would agree. Again, just point out that what said, the other guidelines like the kidney care clinic guideline, as well as the referral projects, they do integrate with the best practice guideline for home HD, and the final document will reflect that again, because it is a tool, it is an overview. The intention is that you'll be able to refer to it and use the links within it to access the relevant guidelines from within it, um, for greater detail, because there are these detailed resources that are available through BC Renal, and this is only one small part of that. So glad to be able to contribute to the wealth of information that we have available.
Yeah, and I think the other thing I might add parenthetically is that the nice thing about doing such a comprehensive literature review and seeing what is evidence-based versus opinion-based, it also generates ideas for new research. I mean, I was thinking about the rope ladder versus buttonhole and whether or not one could do a trial, to actually demonstrate which is better, or is it really dependent on the individual? There are many questions that remain unanswered. And I think that that's the other value, is that where guidelines identify things that are not known, that actually helps to guide others. So there is a question in the Q&A. Mark Elliott, great job. Wondering if you could speak to the strategies to encourage individuals who start on in-center to pursue home hemo, as they often get stuck as an in-center approach. So I think that's quite timely.
Yeah, of course. I mean, yes, as we've all seen, there's a bit of inertia. Once the patients get comfortable, on in-center, they stay there and they get frailer, and then their opportunity to pursue something like home HD is lost. Um, the algorithm that I showed is a bit idealistic in a way. That's assuming that these patients have been captured, from A to Z, from ideally, the kidney care clinics. That being said, we all know that there are these people who crash onto in-center. Really, the key for these patients is what I mentioned. So, hopefully they would have had, number one, some exposure to the CKD clinics and some early education. So we want them to not be totally new to the idea of home HD. And then the key is, once they do, unfortunately, crash land or urgent start onto in-center HD, that they get captured early. So that's one of the emphasis in the literature about having, what we do have in BC, care coordinators, people who will identify these patients who could be suitable and make sure that they have people approach them early, to discuss the possibility of home HD. One of the other ways to capture patients early, and I did mention briefly, was that educating all staff about home HD, which is one of the reasons that I hope to do through this talk. But that's also integrated with what's happening in the referral project as well. And Dr. Boynan also has this. He has like the crash study. Again, this is just trying to get patients early, to have people and the MDT discuss with them early, as a form of transitional care, as it were, to get the patients as soon as possible back into the algorithm down towards HD. So yeah, it's really key that early intervention and early education things.
So maybe another question on the subject of buttonhole versus rope ladders. Is it fair to say the concerns around infection risk with buttonholes cited are likely based on in-center use rather than single cannulator home hemo?
Yeah. Look, definitely. I mean, a lot of the evidence is really surrounding in-center HD. So the consideration isn't there's some only limited observational data in regards to home dialysis patients who, as I say, that they're very distinct groups. Your training, if you train someone properly with the hygiene and the proper technique, are those people going to who are of course directly invested as the patients directly into their own care? Are they going to be better at taking care of their access than your in-center patient who's not as engaged with their care? I think that's a very valid question, and that's in fact, what we do see. A lot of the programs across the province, do buttonhole, and they do not have the kind of problems that were identified in the literature. The patients do very well. They have limited infections. Um, so yeah, the KDOQI guidelines are, I think, being careful, and they're referring to the literature for in-center patients. As Dr. Levin points out, it would be good to do something a bit more detailed for home HD patients, but I guess that's a whole different project.
Yeah. And actually, Carolyn was asking whether or not there's a module or planned module for optimal waste management and minimization in the home setting. It's interesting.
Yeah,
I could probably take that one if you want, Lap.
sure. Yeah.
Yes, but no, Carolyn, that would be the answer. So definitely a recognition of it, and we are engaging our vendors in particular about the recyclability and the planning for that. We're deferring having more formal meetings, and in fact, we'll be inviting you to participate in those meetings with the vendors for the new year. And certainly, as we come into our next contract negotiation cycle, I think that is going to be an element that we will introduce and try to maximize as much as we're able to. But do we have anything in place right now? Nothing formalized, but there's lots of local initiatives. And as you probably know better than I do, Caroline, the interesting thing is, even though the jug that's used for the dialysate solutions looks very much like the milk jug I use for my milk at home, because there isn't a 20-cent deposit paid by the manufacturer on it, the recycling facilities will not often accept it. And it's some of these little craziness things that I'm sure you bang your head on the wall about, that we're only learning about. So we're really trying to put some pressure back to the vendors to create a mechanism by way of how we can try to minimize and divert some of this.
Yeah, I mean, I think it's a good point, and I was going to actually also say, like, I think what also Carolyn was asking is whether or not even just helping people within their own home, how would they minimize use of disposables and things like that? And are there that might be an interesting other side project, not for this week or month, but what is it that you could use less of or not use a disposable and wash things? Like, there are things that I'm not sure. Like at home, I think that's what you were also referring to, Carolyn, but not just the disposal. Costs and subsidies, Dr. Perkel was asking about in terms of BC, what
Yeah, I'm not sure, but yeah, how in detail I can sort of talk about that. But I mean, look, I know that it's in process, like subsidies to support patients with some of the costs incurred for them while they're on HD. So, electricity costs, water costs, waste disposal costs.
yeah.
So those are internationally, that there's some support for that. Not yet in BC, which is a recognized deficit, and that's why there are ongoing discussions about it. Although it's not so set in stone that I could tell you exactly what it's going to be. But yeah, it's definitely in the pipeline.
Yeah,
Yeah,
I think
working towards it. We're working towards it, but we actually had gotten to the point of submitting a business case and a business note to it. But unfortunately, with some of the fiscal challenges right now, it has been something we've had to put on the sideline for now. But we would hope in 2025 to reinvigorate it. BC, or the Kidney Foundation, is certainly interested in working alongside with us for dispersing a small amount of money to cover the additional cost of electricity, water, plus or minus garbage costs for our patients at home. We definitely recognize that we should not be creating a financial barrier, but getting the dollars to flow sometimes takes a little bit longer than I would love it to. Recognize though, and we're working on it.
I think it's fair to say, just in case people don't know, the renovations in the home for home hemo are paid for, and all of the supplies and everything else. I think a lot of the patients initially think they have to pay for the machine or pay for something. So again, it's not enough, but it's certainly a lot if they do need a renovation. Mike, I think it's up to a certain amount of money. Is that right?
On average, it's an install on average is about $8,000 that we're paying, and takedown after somebody is not doing is around $1,500 to $2,000, and we cover all those costs. That's correct.
Yeah. All right. Well, on that happy note about money, so the reason he was asking was if you can't train, if you're training for 6 weeks and can't work, whether or not you qualify for disability or EI or whatever. It's an interesting question for sure, and maybe something that can be thought about from the social worker's perspective. Yeah.
There are funds from the Kidney Foundation one-time training grants that can help to defer some of those costs, not completely, but it can at least help to cover some of the housing costs, and that's available in all 5 health authorities.
Great. Thank you. Well, on that happy note, I believe this is the last of our, and a good place to end the academic province-wide round sessions for 2024. Very fitting that it's also LAP's last month in Canada. So thank you for all the work you've done and everything you've contributed, but also good luck with Australia and everything. And thank you everyone for participating in province-wide rounds. I think we've had over the last 6 months, almost all of them have had over 50 people attending each of the province-wide rounds. As you know, they're all available on the website for you to go back and look at. And this will be yet another one of those really excellent ones to refresh our memories. So thanks very much, everybody. And thank you, LAP, and happy holiday season to all. Bye.